Hello, my name is Jon Harvin, and I am an Associate Professor of Surgery at the McGovern Medical School at UT Health and a trauma surgeon at Memorial Hermann Hospital, Texas Medical Center. Today, I will be discussing our trial of multimodal analgesic strategies in trauma, or the MAST trial. While the coronavirus pandemic continues, the opioid epidemic that was ongoing in the United States beforehand continues to worsen. Legitimate prescriptions to opioids from healthcare encounters was a substantial driver of the opioid epidemic. While this appears to have improved, trauma surgeons care for severely injured patients and need thoughtful, effective, and responsible methods to treat acute pain after injury. In 2013, we implemented a multimodal pain regimen at the Red Duke Trauma Institute that included intravenous followed by oral acetaminophen, celecoxib followed by naproxen, pregabalin followed by gabapentin, scheduled tramadol, lidocaine patches, and as-needed oral opioids for breakthrough pain. The regimen was initially very controversial. It took years to get physicians and nurses and patients on board that severe acute pain could be treated by a largely oral opioid minimizing regimen. The regimen had three issues, however. First, it was relatively expensive as it included intravenous acetaminophen, celecoxib, and pregabalin. Second, it wasn't generalizable as some medications were not on formulary at other hospitals and not covered by insurance at discharge. And lastly, it included scheduled tramadol, which really made it not truly an opioid minimizing regimen. Organically, a second regimen came about and included oral acetaminophen, naproxen, gabapentin, lidocaine patches, and as-needed oral opioids, a truly generic and opioid minimizing regimen. The MAST trial randomized all adult patients admitted to the trauma service at our trauma center to one of these two regimens. This included patients admitted to the intensive care unit, to the intermediate unit, and floor, so all severities of injury. Simply put, the generic multimodal regimen, or MAST MMPR, resulted in lower opioid exposure, no clinically important difference in acute pain scores, and probably most importantly, a 5% increase in patients discharged from the hospital without a prescription for opioids, including tramadol. There was more nuance in the results of the trial, and I encourage you to read the manuscript to evaluate them for yourself. But briefly, while the MAST MMPR worked better overall, it worked differently depending on which unit the patient was admitted. For the general public, the main takeaway from the study is that opioids should not be considered the pillar of treatment after For the general public, the main takeaway from this study is that opioids should not be considered the pillar of treatment for acute pain after injury, even severe injury. For the medical community, this trial is another example of how acute pain after injury can be effectively treated in an opioid minimizing manner. Thank you.